Hi, everyone, and welcome. I'm Dr. Katie Berlin. I'm a member of the medical team here at Clinicians Brief, and I'm very excited to welcome you to tonight's webinar, Veterinary Dental Radiology, Interpretation of Common Pathologies, and Tips for Capturing Hard-to-Get Images. Before we begin, I'd like to take a moment to help you familiarize yourself with the webinar platform. You can rearrange the console to your liking by expanding or shrinking those boxes on your screen. And if you want to bring something back up that you've minimized, use the icons at the bottom of your screen. If you're joining us live, you can ask questions anytime. You don't have to wait for the end by typing your question in the Q&A box in the bottom right side of your screen. If you have technical difficulties, you can also alert us by submitting your question in that Q&A box, and a member of our support team will work with you to correct the issue. But Dr. Burning will be coming back to those questions at the end of the presentation, so you can submit your questions anytime, but we'll answer them at the end. The webinar is approved for 1 hour of CE. So if you're joining us live, you can, if you view the webinar for at least 50 minutes, you can access your CE certificate by clicking on that yellow icon in your toolbar or in the box at the bottom right corner of your console. If you're viewing the presentation on demand, please reference the CE information box in the bottom right of your screen for instructions on how to receive your CE credit. This event today is available with support from our sponsor, IM3, and they're generously offering 10% off any imaging needs throughout the webinar and for up to a week following this live presentation. We'll share contact information at the end, so stay tuned for how you can get that discount. Joining us today and sharing her expertise is Dr. Jamie Burning. Dr. Burning is the owner of Veterinary Dentistry and Oral Surgery of Ohio and a consultant for multiple zoological institutions. Dr. Burning's passionate about all aspects of dentistry and particularly enjoys endodontics, oral surgery, comparative dentistry, and diagnostic imaging using cone beam CT. She enjoys teaching veterinarians, students, technicians, and staff. So you're in great hands today. Take it away, Dr. Burning.
Thank you so much for that introduction. And thank you everyone for joining us, whether you're viewing this live or watching this after the fact. Give yourself a pat on the back for being here. It's always a great opportunity, and we're always honored to be able to share some information with you. You're doing great things by learning more so that you can do better. So let's get started. We'll talk a little bit about why would we take dental radiographs, and then we're going to go through a little bit about what we need to take dental radiographs, and then from there we're going to go into how to interpret them. So why would we want to take radiographs in practice? Well, when we have animals that present to us with injured or fractured teeth, and those are going to be some of the most common things that you're going to see when it comes to oral pain, you're going to see a lot of fractured teeth. And so we want to make sure that we're getting radiographs of those teeth and see what's going on at the tip of the root of the tooth, or that apex there. When you have discolored teeth, you're going to want to take radiographs of those. As we know from some studies that have been done, more than 90% of those discolored teeth are actually dead. So we need to be doing something about them. We want to take them pre and post extraction, of course. So if you're ever taking out a tooth, you absolutely need to be taking a radiograph afterwards, and of course before as well. But one of the reasons that we take those post-op rads, it's not just because the dentists like to tell you to take them. Fortunately or unfortunately, we live in a world that has a lot of law teams in it, and it's definitely recommended that you are able to back up the work that you're doing. And it's really important, especially in maybe some of your small dog friends that have those really big mandibular molar teeth, that after you've taken one out, you have the evidence to show that you did indeed not break that jaw. So let's say that you did an extraction on a mandibular first molar tooth, for instance, and that small dog went home and you didn't break the jaw, and it went home and it jumped off of an ottoman and it broke its jaw doing that. So let's say that happens and you don't have your post-extraction rad, it's not going to be so great for you. So I absolutely, that's just one scenario that I know has actually happened, but I would recommend that we take those post-op rads on every single tooth. The other thing is sometimes we leave tooth roots behind very unintentionally, but it's because we didn't see them, because we didn't take the rads post-op, right? So we want to make sure that we're doing that. Another thing is going to be tooth resorption. So we've probably heard of tooth resorption, and this is pretty common. We see this in cats a lot. We're starting to see it more and more in dogs. And so we'll want to make sure that we know exactly what's going on with those teeth that have those resorptive lesions going on, because otherwise it's going to be really frustrating, one, to know what to do to treat it, and then two, to figure out, do we have everything that we intended to get out when we were treating those teeth with tooth resorption. Another thing, periodontal disease. Of course, that is, again, periodontal disease. When we talk about that, it's perio meaning around, odont meaning tooth. So periodontal disease of those structures around the teeth. And we're going to get into this, but that's when we're looking at our bone height in particular. We see these patients in our exam rooms and we're identifying, I think this is a stage this or a grade this, or however your practice is doing things. And you're kind of scoring maybe your dental procedure in advance of getting in there. And maybe you're saying that based on what you saw for periodontal disease or suspected bone loss prior to the procedure. And that's really going to tell you what you have going on for that. Endodontic disease and treatment. So what that means, if we think about an endodontist on the human side, for instance, we're going to think about root canals. And that's where we would go to have root canal therapy performed. So endodontic disease means disease within the tooth. So that's going to be the disease that we have inside of the pulp chamber. So when we have inflamed, diseased, infected, necrotic pulp inside of the tooth, that's going to be endodontic disease. We can see that show up as a periapical lucency. Peri, again, around. Apical is the apex of the tip of the root of the tooth. So when we have something around the tip of the root of the tooth there, that's going to be when we see that endodontic disease. If you have masses or tumors in the jaw or anywhere in the mouth, you want to make sure that you're evaluating those, getting some radiographs, seeing if those are into the bone, seeing if that's also affecting the teeth in that region. Evaluation of missing teeth, and this is a big one. We want to make sure that if we are in the mouth and we see that some teeth are missing, we're taking radiographs of that. And that includes when we have our patients on the table when they're first coming in and they're young and we're looking in the mouth and maybe we don't see those 4 premolars that should be in front of that big molar tooth on the bottom. If we don't count 4 premolars in front of that in our dog friends, we need to say, let's get some radiographs. And if you notice that on your spay and neuter patients, if you notice that first premolar tooth on the bottom is missing, you definitely want to take a radiograph of that, because it's not always that these teeth are actually missing. And if they are, that's fantastic. But for instance, I had a dog today, had unerupted 304 and 404. And that dog presented to me for a fractured tooth and a root canal. So making sure that we're really getting in there, counting these teeth, evaluating those supposedly missing teeth or apparently missing teeth. We can circle them on our dental charts, but we want to make sure that we're taking rads so that we can figure out if they're actually just unerupted. And if they're unerupted, are they causing big problems under the gum line? Then we have our carious lesions. This is our cavities. We did not used to see a lot of cavities in our dog patients, and we are starting to see those more and more. That has to do a little bit with people now having their pets living inside of their homes and sleeping in their beds and hanging out in their kitchens and all that kind of stuff. So we love our pets, which is fantastic, but we didn't used to feed our pets sugar. And nowadays, it's really easy. If you go to the training treat section of the pet food store, you can find all kinds of sticky, chewy treats that are oftentimes small. And if you start to look at the ingredients on those, oftentimes in the first 3 ingredients, you're going to find a type of sugar product. So that gets stuck in the back on those occlusal or flat chewing surfaces of our dog friends. So on our molar teeth in the back, we start to see cavities. Why do cavities matter? Well, because if we catch them soon enough, we might be able to do a filling like in human dentistry. But if we don't, and those cavities get into the pulp chamber, we're going to end up with endodontic disease. Again, disease inside of the tooth there. Evaluation of oral pain is going to be a really big one. Jaw fractures, of course, or any kind of misalignment of the jaw, and you might find out that it's due to a fracture. And then here's the big one, guys. This really, really should be happening. Survey films during all routine professional cleanings. So anytime that you have a patient on the table for a dental procedure, we really need to be taking full mouth radiographs. If you have the equipment available in your practice, it should not be an optional thing. The owners shouldn't be selecting if they want rads or don't want rads. We really shouldn't let them pick if they want 2 rads or 5 rads. it's really not up to them because they don't fully understand the value of those radiographs. So, one of the things that I find is really big for veterinarians is that we don't like doing things that we're not good at, right? And the thing about that is that learning dental radiography is hard when we're first getting started. But once we become comfortable and competent at evaluating radiographs, it's easy to want to have the information. When we have the information and we don't know what to do with it, it's a little bit scary. So we want to get to the point where we have that information and we can make decisions with it and not be quite so intimidated by what we have in front of us. So some stuff that you want to make sure that you have is, you're going to have your generator, of course. That's how you're going to get these x-rays to show up. But then you're going to have either a phosphor plate system, which would be your CR system, or your DR system, which is a digital sensor. And so many companies sell a size 2 sensor. We are super fortunate that in the veterinary dentistry market today, IM3 actually has come out with a size 4 sensor, which is fantastic. And it's a larger sensor. It makes it so that you can quickly, because I know a lot of people worry about the amount of time under anesthesia, but you can quickly gather a lot of information with that larger sensor. So that's something that is available. This would be an example of just some of the sizes of those phosphor plate system that we have here. This is the CR8. This is IM3's new unit, and I can speak to the software that they have come out with this new unit, and it is great, very user friendly, and the quality of images are fantastic. These plates are really nice because they can be really small or they can be really big, so you can use them kind of flexibly depending on what your needs are in practice. So absolutely look into those if you're looking to upgrade or to get started with your dental x-rays at your practice. So when we are looking at dental radiographs, we are looking at them as though the patient is facing us. So that's really important to keep in mind. So we're going to look at our maxillary teeth with the crowns facing down, and then we're going to look at our mandibular teeth with the crowns facing up. So you can see that these are all maxillary teeth and all of the crowns are facing down. It's important to be able to start to identify which teeth are on a radiograph. So as you start to see these, and these are all, this would be a full mouth dog radiograph set. And this is actually the radiograph set that I turned in for my residency. So you can see that all these radiographs are very nice and they're pretty symmetric, and that's fantastic. I don't need you guys to take perfect radiographs in practice. I just need you to take diagnostic radiographs in practice. So what does that mean? What's a diagnostic radiograph? We need to have 3 millimeters around the apex, or the tip of the root of the tooth there. We need to have those 3 millimeters around that apex in order for it to be considered diagnostic. That's going to allow us to appropriately evaluate that periapical region. So those would be our full mouth rads on our dogs. And then you can see our full mouth rads on cats, of course, are going to be fewer necessary shots to take. And then also we're going to have more teeth kind of on these images because the cat mouths are, they're tiny, right? So, but it can be a little bit tricky sometimes to get in there. So one of the things that I want to point out here is that when we are looking at this 07 tooth here on the bottom can be one of our harder teeth to get in our radiographs. This tooth right here, we can get that in our images if we are taking a lateral view of our canine tooth. So that will make it so that if you are shoving that sensor down in really far on your cats to try to get the mandibular cheek teeth there, an easy way to be able to evaluate those 07s, which, by the way, are the most common teeth in the mouth to be affected by tooth resorption. So super important to be identifying on your radiographs. So making sure that you're taking all of these kind of views. So let's just talk a little bit about normal radiographic anatomy. When we are looking at our teeth, of course, we have anything that is above the gum line in a normal healthy tooth is going to be considered the clinical crown. Anything that is below the gum line in a normal healthy tooth is going to be the root of the tooth. So on this radiograph, you can see there in blue is the mandibular canal. And so things are going to look a little bit different when they're overlapping the mandibular canal. Why? Because that's a soft tissue structure. That's where we have our inferior alveolar bundle running. And so when we have roots that are overlapping with that, it's just going to look a little bit different than it does when it's overlapping with bone. And then I outline here just that furcation so that we can see. It is actually called a furcation, not bifurcation. We often hear the term bifurcation or see that in records. So just note that that is furcation. That's in between two roots. So descriptions for the pulp, just to kind of cover this quickly, the pulp cavity is the space within the tooth. And then if we want to break it down into crown and root sections, we would say the pulp chamber for the crown portion of the tooth, and then the root canal for the root portion of our tooth. Anytime that we are looking at radiographs, we want to make sure that we have a systemic approach. I'm guessing that you guys have a really good way of making sure that when you're looking at, for instance, thoracic rads, you're having a system in place to make sure that you're also evaluating any of the bone structures that are in that radiograph, right? As well as the heart, as well as, you know, everything else that's on that film. So when we're doing our dental radiograph evaluation, in a similar way, we want to make sure that we are able to identify what we're looking at. So as we go through the radiographs today, I want you guys to think in your head as soon as a new image pops up on the screen. Is this mandible or maxilla? That's what I want you to think about first. Then I want you to say, is this the left? Is this the right? Okay. And then once we've established what we have there, we can identify which teeth are present in this radiograph. And you guys, as long as in practice, all you're ever doing is rotating your images, you can always identify which teeth are actually in your radiograph. So it'll be easy to identify which teeth are in your radiograph. If you flip those rads, then you're going to get yourself into a sticky situation. But the reason that I tell you that you'll be able to identify which teeth are in your radiograph is so that we don't have to scramble really quickly and identify every single radiograph before we can take the next one every single time, because it's okay. We should be able to tell which teeth are there. We want to make sure we're looking at that periodontal ligament space. That's going to be the area between the root structure and the bone. So we want to look at that and see, is it widened anywhere? Is it widened especially at that apex or that periapical region? Is it normal? Is there tooth resorption? So we're going to identify that periodontal ligament space there. We're going to look at our alveolar bone height and density. We want to make sure that that's normal. We're going to look at that periapical region, and then the roots, the pulp chambers. We're going to look to see, is this an old animal? Is this a young animal? Is that tooth, has it been dead for a long time? How can we know all of these things? And then the least important thing to have in your radiograph, honestly, it's good to have, but the least important part is the crown. Why? Because you can see it when you look into the mouth. Everything else absolutely needs to be there because you can't see it. But we need that bone height. We need that apex. We need 3 millimeters around that apex. So let's chat real quickly about this. We use the modified trade-in numbering system. This is really important because when we're using this 1, 2, 3, 4 for our quadrants, the first digit's going to represent the quadrant. So our 100 quadrant is going to be our upper right quadrant. The 200 quadrant is going to be our upper left quadrant. 300 is going to be lower left, and then 400 is going to be our lower right. We need to keep that in mind as we go through all of these radiographs. Our fourth premolar tooth, top or bottom, left or right, is always going to be an 08. Our first molar tooth, top or bottom, left or right, cat or dog, doesn't matter, is always going to be an 09. As long as we know those things, we can identify any other teeth in the mouth. So real quick, again, we'll say periodontal disease. Again, peri meaning around, odont, tooth, periodontal disease, disease of the structures and tissues around the tooth. This is not disease of the tooth itself. You might be in the habit of calling something dental disease. Dental disease is just kind of a garbage term. We hear it all the time. I'm not going to get on a soapbox about not using that term. It's okay. It's just not descriptive. That's the problem with it. So within the categories of diseases within the mouth, periodontal disease is one of the most common things that we see. It happens in so many of our patients. But this is when we have disease of the structures of the alveolar bone, the cementum, the periodontal ligament, and the gingival tissue. Those are the things around the tooth. So the degree of severity of periodontal disease really describes a single tooth. So when we're saying that a whole mouth has the same severity of disease, not really accurate, except I guess on some of those really, really bad mouths, you might be able to get away with that. But usually your patients are going to actually have different stages of periodontal disease in their mouths. Here are some stages of periodontal disease. So normal is going to be just 0. That's going to be our no gingival inflammation. Periodontitis is not present. those are pretty rare. It's going to be most of our young patients. Then we get into our stage 1, or PD1 is how we would abbreviate that, gingivitis without attachment loss. So this is really just we have inflamed gum tissue and that's it. Then we go to stage 2. So that's going to be our periodontal disease stage 2, PD2. That's early perio disease. So that's when we have less than 25% attachment loss. Or we might have stage 1 furcation involvement in multi-rooted teeth. Stage 3, this is our PD3, and that's going to be our moderate perio cases. That's where we have between 25 and 50% attachment loss. And that could be stage 2 furcation with our multi-rooted teeth. And then we have stage 4, right? And I put this in red here because these are the ones that they've got to go. So our stage 4 teeth are going to be when we have advanced perio. This is when we have more than 50% of our attachment loss gone, or 50% of our attachment gone. So we have that more than 50% of the bone that's supposed to be holding our teeth in place, no longer present. And this could be our stage 3 furcation with our multi-rooted teeth. So what does that look like? When we are looking at that attachment loss or that bone height, we are measuring from what's called the cemento-enamel junction down to the apex. Cementum is what goes around the root of the tooth. Enamel is what goes around the crown of the tooth. So where the cementum and the enamel come together, that's called our cemento-enamel junction. So that would be here. And that's where our crown and our root come together. So we measure from there all the way down to here, which is our apex, right, or the tip of the root of the tooth. So when we break that down, we can see our 25% bone loss up to 25% bone loss up to 50% bone loss, and then greater than 50% bone loss. And those are going to be our stages, and that's going to be how we make some of our really big decisions on whether or not we're going to keep a tooth in the mouth. We have a couple types of bone loss, and we can have horizontal bone loss, and that's going to be what you see when all of the bone has just started to go away in a horizontal fashion. In this radiograph, we're lucky enough that we also can see some vertical bone loss. So we can start to identify that vertical bone loss is going to be when that bone loss goes right alongside of that tooth root. So endodontic disease, like I keep mentioning, that's disease within the tooth itself. So I have on here chevron versus endodontic disease. Why? Because we don't want to take out healthy teeth. So healthy teeth might have what you see here on the left right here, and that is actually a normal anatomic structure. So that is, we're able to kind of follow this white line all the way around, and you can see that our tooth would basically slide into that. That is the periodontal ligament space. It's a little bit of a widening there. It allows our teeth to be able to not snap off as we chew, as we do things with our teeth, right? On the other hand, over here, you can see this halo appearance, which is not just a smooth round thing at the end of the tooth like we had on the other side, but over here we have this halo appearance, and then we have kind of around that apex, a blunting of that apex. We no longer have a really distinct periodontal ligament space, which is this kind of black space going all the way around the tooth here. We no longer have that. We kind of lose, like, where is that in this area? Yeah, it's gone. So, you know, those are the things that we start to look at when we say, oh, okay, that tooth is pretty diseased, actually. We got to do something about that. A little bit about pulp canal maturation. So one of the absolute most cool things that exists in dentistry is what is called the dentin pulp complex. So throughout the life of the tooth, the pulp, which is our living structure on the inside of the tooth, so that's our blood vessels and that's our nerves and that's all of our soft tissue stuff hanging out on the inside. It is responsible for laying down and creating this stuff called dentin, which is hard tissue. So it's made up of lots and lots of tiny little tubules. So throughout the life of the tooth, what happens is that the pulp chamber gets smaller and smaller and smaller and smaller, and our dentin becomes wider and wider and wider. And so you can see in a very young tooth here, we have a really wide pulp here. And then over here, we just have this really, really thin as we kind of go there. And you can see that that tooth is primarily made up of dentin. And that's what allows that tooth to have such structural integrity, is that it's created mostly of dentin. And that's because the pulp lays down that dentin throughout the life of the tooth. I think it's absolutely fascinating. So let's get into tooth resorption here for a minute, and we'll talk a little bit about cat tooth resorption. So these couple of slides are going to go through feline tooth resorption, and this is type 1. So we have 3 different types. Type 1 is going to be when we have a focal or multifocal radiolucency with an intact periodontal ligament space. So we can see that here. We see this big kind of focal lucency, and then we have an intact periodontal ligament space. So we can see that all the way around this tooth, we have a line that goes around it. So why does that matter? Types of tooth resorption matter because it determines our treatment plan. So we are going to make sure that if we see type 1 tooth resorption, we are fully extracting the tooth. Crown amputation, not an option. That is an inappropriate treatment plan for this type of a tooth. So this would be type 1 tooth resorption, focal, multifocal, radiolucency, intact periodontal ligament space, which brings us to type 2. Type 2 tooth resorption. This is when we have a narrowing or disappearance of the periodontal ligament space in at least some capacity. Now, we'll probably also see decreased radiopacity of part of that tooth. So we have this term called crown amputation. I don't love the term just because when we hear that, we would think, oh, okay, well, all I need to remove is the crown, right? Crown amputation. No, not true. What we need to remove is identifiable tooth structure. So I like to call it modified extraction technique, where we actually are removing whatever we can see of those teeth that have tooth resorption in them. So type 2, again, going to be our narrowing or disappearance of the periodontal ligament space in at least some capacity. And we want to make sure with these teeth, we are removing identifiable tooth structure, okay? And it's also important to note that if you see tooth resorption, type 1 especially, because it's going to be associated with the crown of the tooth where you're starting to see the radiolucency, those need treated. Type 2, if it is just in maybe the apical third, we don't have to immediately jump to taking out those teeth. We might be able to monitor those teeth, and it's unknown how long we're going to be able to monitor those, because tooth resorption is a predictably unpredictable condition. So I say that because it is predictable in that we know it's going to progress. It's a bit unpredictable in that we don't know at what rate. So also worth noting is that type 1 kind of looks like an eye. Type 1 can be caused by inflammation, which can be related to periodontal disease. So periodontal disease can go right along with type 1 tooth resorption. So type 3 tooth resorption is when we see characteristics of both type 1 and type 2. That gives us type 3. So when we see this, this is going to be type 1, remember, focal or multifocal, radiolucency. That's going to be this. That's going to be this with an intact periodontal ligament space, right? We can see this black line going all the way around. Then type 2, narrowing or disappearance of the periodontal ligament space in at least some capacity. So we have that going on as well. So on these multi-rooted teeth where we have type 1 and type 2, that's actually type 3. So keep that in mind because we need to treat those differently. So this would be type 1 tooth resorption. So when we look at this radiograph, we immediately should be able to say, this is a cat. This is the maxilla. This is the right side. What do we have going on? Well, good thing we have this arrow here, but also this is what we have going on, right? Type 1 tooth resorption, focal or multifocal radiolucency with an intact periodontal ligament space. Full extraction of that tooth. We have to get the entire thing out of there. Now, what do we see here? This, again, we're going to say, okay, that's a cat for sure. That's a mandible. Those teeth are on the left. Remember, we're keeping in mind that this animal would be looking at us, and that's how we would be seeing these teeth. So what's going on here? Well, we have bone loss going on here. Okay, so do cats get periodontal disease? Of course they do. But does this look like periodontal disease? Well, I don't know. Maybe not. I had a friend send me a radiograph that looked very similar to this, and I told her to check her cat to make sure that it didn't have a malocclusion. She wanted to know how I knew that, and I knew that because we see this all the time. So if you see a radiograph that looks like that and you haven't checked your cat's occlusion, you're going to have to extubate your cat and you're going to have to check your cat's occlusion. Why? Because right here, this class 1 malocclusion where we have palate eversion or going in towards the palate of our maxillary O8s causes a defect at the mesial root of our mandibular first molar tooth in our cats. So we want to evaluate that. It's super important that we know what's going on with that because that is going to make sure that we know how to proceed with treatment for these guys. We can't just take out that mandibular molar tooth and be fine. We might also have to evaluate and do something with that maxillary fourth premolar tooth. Which brings us to this radiograph. So this, we're going to say cat or dog. Well, this is a dog, and we start to be able to identify which teeth are in this radiograph. Mandible or maxilla, this is going to be mandible. Is this going to be left or right? This is going to be left. So when we look at this, this is our first premolar tooth. And remember, I told you it's the most common tooth in the dog in the mouth to be unerupted. So this is an unerupted tooth. And the reason I put this in here is because if you guys are doing this in practice, you don't have a cone beam CT like I do probably. So that's okay. The reason I take this and put this radiograph in here is because if you need to get that tooth out, you need to figure out where is that tooth from the inside to the outside. And you can take a straight on view, and that's going to give you a little bit better identification of where in relation to this canine tooth is that unerupted tooth laying. So that when you get in there, you're able to identify where you need to be in order to get in there and remove it without causing any damage to the canine tooth. Well, that brings us to this radiograph. So if we look at this, we say cat or dog, and we see this tooth over here is a canine tooth, and then we see all these premolar teeth, and then we see these molar teeth back here. Well, this molar tooth right here immediately tells me that this is a dog, okay? And this is the maxilla or upper jaw, and this is going to be the right side. We look at this and we say, well, I see something that looks off right here. And it looks like we have an absent tooth also. Yes, you're absolutely right. This 8 is missing. Okay, well, guess what? A very well-intentioned veterinarian accidentally, while removing the 8, cut into this 7. Guys, I see it a lot. So we want to make sure when we are separating those mesial roots, we don't accidentally cut into the teeth in front there. We don't want to cut into that 7, that distal root there. This is what happens. That tooth can't keep on living when we cause that much trauma to it. So let's say it happens, then what? Let the clients know, take out the tooth. This is doing a disservice to the patient by leaving it in there. So if you're causing trauma to the teeth adjacent to the tooth that you're taking out, obviously it's not ideal. But you know what? We live in a world where sometimes we make mistakes. We're all going to make mistakes. We need to just let people know that we've made those mistakes and then do what's right for our patients in those situations. And so making sure that we're addressing those is going to be really important. This would be a cat maxilla. And what you're going to see here is a bunch of retained tooth roots, right? A bunch of RTRs. The other cool thing about cats is that we can really start to evaluate their sinuses if we are taking a maxillary rad like this. What we cannot identify easily in this radiograph, however, is the maxillary canine teeth. So don't try to take this view and this view only and try to say what you need to do with those maxillary canine teeth. I know that it would be easier if we could do that, but unfortunately we can't. So we need to take some lateral views in order to figure out what's going on with those teeth. What about this? This is a little bit wild. So this would be a dog, and this would be the mandible, and this would be the right side. And the reason that this radiograph is abnormal is because, well, there are no teeth on the lower jaw in a dog or a cat that have 3 roots. And also, so our 10 there has an extra root, and so does our 11. So our 10 should really only have 2 roots, and our 11 should just have 1. So these are called supernumerary roots, and they're fine. You know, if they're not causing any amount of bone loss or crowding or other problems, you don't have to take out those teeth just because you see those. You just want to make sure that you are marking those down in your records so that you know about them. Why do they matter? Well, you want to make sure you have these radiographs if you do have to take out those teeth, because it's not really very good if you leave a root behind because you didn't know it even existed. This here, this kind of looks similar to that other one we saw. Why? Because again, it's going to be our first premolar tooth in the mouth that's going to be unerupted. Oh, but wait, I see our first premolar tooth and it's erupted. Because even when we count teeth, sometimes we have extra teeth. So this is a supernumerary tooth that is unerupted. And you can start to see on the crown of that tooth right here, you can start to see a little bit of a widening or a halo appearance around it. Well, that could be the beginning of the formation of a cyst, for instance. So super important. Even when we get in the mouth, we count teeth, all the teeth are there. That is fantastic. But hopefully you're seeing by now why we need to be doing full mouth radiographs on absolutely every patient. Look at that, guys. That's crazy, right? But we want to make sure we know what's going on with our patients. So this would be a dog. This would be the upper jaw or the maxilla. And we start to look at this and we say, what's going on here? Well, look at the amount of bone loss that we have along here. Wow, gosh, now that I look at it, that bone should be all the way up here, right? It should be all the way at our cement to enamel junction where our crown and our root are coming together. And it's not, and it's really not on any of these teeth, is it? So we get in there and we say, okay, well, let's evaluate those and let's make sure that we get out the ones that need to be taken out. So let's look at this one. This is, again, the maxilla of a dog. So let's look at these incisor teeth. Well, do they all look okay? Maybe at first glance, but then we start actually evaluating. Let's look at the pulp inside of these teeth. And we start to say, oh, wait. This is my favorite radiographic finding, by the way. Anytime that we have an apparent widening of the pulp chamber, so remember I said that the pulp lays down dentin throughout the life of the tooth. So if we have arrested development of these teeth, that means that they stopped developing, then the pulp chamber stays where it was. And what that means is that it doesn't get any smaller as the rest of the teeth around it continue to have that narrowing of the pulp. So what happens is that these are dead teeth. When we see this on our radiograph, we know that something needs to be done. Because when we have dead teeth in the mouth, there are only two things that we can do. We can either extract them or we can do a root canal, right? So these guys got to come out because these are considered non-strategic teeth. Our strategic teeth are going to be our big canine teeth in the front, so our big fang teeth, and then our carnasal teeth in the back. On the top, that's going to be our upper fourth premolar tooth. On the bottom, that's going to be our lower first molar tooth. So those are our strategic teeth that we like to try to save no matter what. And then our non-strategic teeth are going to be the ones that we're going to be more inclined to take out than to necessarily do root canal therapy on, though you're going to have clients who are going to want root canal therapy on incisors. So I'm just letting you know that those people exist in the world, and that is okay. We love those people. What do we have here? Well, this would be a dog, and this would be the mandible. This would be the right side. So we're starting to get familiar with looking at, okay, I see what I see here, and this would look as though I was looking into the mouth. And then I start to evaluate what is happening here. Well, I like to call these cupcake teeth. That is not what they are actually called. This is that we have fused roots. So what do we need to do about that? We don't need to do anything about it unless the tooth is having some sort of disease around it, periodontal disease, or within it, endodontic disease. In this case, we don't need to do anything with this tooth except admire it for its very cuteness that it has going on there. And then we move on. We make sure we document it. But when we do have to take out these teeth, we don't want to try to section them because then we're just going to break them, right? So it's super important that we know what those root structures look like. So look at this one. Remember, my favorite radiographic finding here, ta-da, that is where we have the pulp chamber that is apparently widened, right? So it looks like it is wide there, but the reality is we don't want to say that it's actually wide. We just want to say that it failed to narrow, or we want to say that it is apparently wider because it hasn't actually gotten wider. It's just failed to get smaller. So that's just a terminology thing that there are some dentists in this world that care a whole lot about that. So just letting you know that that is a thing. What do we do with it? Well, because this is a strategic tooth, we went ahead and saved it. So what do we see here? Well, this is a cat. So, and this is a mandible. We can see that. This is on the left. And we look here and we see, oh, I see a retained tooth root. Everybody always wants to know, when can we leave those? Well, in cats, you really should not be leaving those because cats just love to get inflammation in their mouths. They just love it. So I definitely recommend taking those out. But as you start to look at all of these cat mandibular teeth, especially these mandibular cheek teeth, and everybody has this love-hate relationship with cat teeth. As soon as you start to love cat or get to be familiar with cat teeth, you might love them a little bit more because when we start to look at these, we can say, okay, if I section this tooth here, I know that this root goes in this direction, and that might be how I extract it. This one kind of in this direction, okay? But then we look here and we say, oh, this one's going to need to be extracted in this direction. And I'm not saying these roots need extracted, but I'm saying if they did. And this one here. Now, as we go along and see more mandibular cheek teeth in cats on radiographs, I want you to pay attention to just how different they are. And you're going to be really happy to have radiographs in front of you when you're doing dentistry on cats so that you know where to section and then you know exactly which direction to take those teeth out. So this is going to be a dog mandible. And the reason I put this in here is because we look at this right here and we might say, oh, you know what? Is that fractured, or do I have two different bone heights on either side of the mandible? So just keeping in mind that maybe you need to take another view. Maybe you really need to get in there with your probe, figure out what's going on there. Whoa, what do we have going on here? Well, we have a whole lot of teeth going on here. So we look at this and we say, yeah, we definitely have a whole lot of teeth going on here. So making sure that we can identify, are those teeth causing crowding? What's going on? What do we need to know? What do we need to do? So here would be another fantastic example of mandibular cheek teeth in cats that look very different than the ones that we were just evaluating. Why does that matter? Well, because if we are going to section this tooth and extract this root here, we want to extract this root in this direction. We would extract this root in this direction. This root has a little bit of a curve on it, so it's going to go like this. This one here would go like this. This one would go like this. Hopefully the laws of physics there are starting to make a little bit of sense. If you're not used to paying attention to which direction these roots are going, how are we going to get them out? And then we get them out with very little bone removal, because that's fantastic. Bone removal is the most painful part of the procedure. We know that from human dentistry. Here is a small dog. That is a really common lesion that you're going to see in small dogs. So that is endodontic disease. You know, we might refer to that as an abscess tooth. I certainly have colleagues who are going to tell you not to call it that. When you're talking to your clients, oftentimes it's easier to call it that. It's disease within the tooth that's going to the tip of the root of the tooth that's causing a problem. Wow, what do we see here? Well, we see type 2 tooth resorption. This is a cat, this is the mandible, we know that. So this is gonna be our 7. This tooth is pretty much gone. This is probably that little pink bleb that you see when you look into the mouth, right? So then this here, what do we need to do? Well, if that is at the level of the gum line or higher, we definitely need to treat that tooth. This guy over here, yeah, absolutely. We need to make sure we're treating things that are causing pain in our patients. If it is completely in that apical region, or even within the, 1/2 of that root section, we can monitor some of those, and some of them might progress really rapidly, and some of them might be able to hang in for a little while. This radiograph is mandibular incisor teeth in a dog, very similar to the radiograph that got me started in veterinary dentistry. There's a tooth root right there. Similar to what I found in a patient when I was developing dental radiographs by hand. I found something like this, and I referred that case to a dentist because I didn't know what to do. So it's jagged, it needed to come out, right? So when we see tooth roots that are there, we need to get them out, particularly if they are jagged and look like that. This is my least favorite thing in all of dentistry. You can probably tell that I have lots and lots of favorite things in dentistry. Tooth resorption in dogs is my least favorite thing in dentistry. We see a lot of it, and the reason that I don't love it is we don't have a ton of studies to show us exactly how we need to be treating these teeth. What we do have are some papers, some really great papers on the types and classifications of this tooth resorption in dogs, because it's not the same as in cats. It's more similar to humans. We're not going to get into all of that today, but we need to know that when tooth resorption in our dog friends is at or above the gingival margin, we need to do something about it. We need to remove that identifiable tooth structure. Are you going to go digging in here to get out a tiny little ball of tooth that's at the apex? Not if it's going to cause more harm than good, okay? And I will give the disclaimer that that is my opinion, and that is how I treat these teeth. I remove identifiable tooth structure. We don't want to just get in the habit of doing a crown amputation, but we definitely want to treat these where if you look in the mouth and you still see tooth structure, you need to get it out, or radiographically. But you're not going to, when you don't have a mid-root section of a tooth, you're probably not going to be able to get to that little apical ball. So here you can see this is a mandible in a cat. Again, if we are just looking at how would I extract these, that's how you would extract those. But this, we have type 1 tooth resorption, right? Type 1 tooth resorption is a focal or multifocal radiolucency with an intact periodontal ligament space. This tooth is going to have to come out completely. So we don't get to crown amp these guys. They have to go. So make sure you get that out completely. What is this? Why did I put this in here? Well, this is a big dog, and this is a big dog with persistent deciduous teeth. Oh, but it looks like the one over here on the right actually has just a retained tooth root left. Yeah, because the owner thought that that tooth fell out before they made it to me. Well, that tooth didn't fall out, right? So this is a Bernese Mountain Dog, guys. You can see these persistent deciduous teeth in any size dog. I know we think of them in our Yorkie friends. I know we think of them in all of our small dogs. They can happen in any size dog. If they fall out, make sure that you're getting in there and taking a radiograph to make sure that that root is not just left behind, okay? Here we have more tooth resorption in cats, another mandible, right? So this is going to be our type 1 tooth resorption. We have focal, multifocal, radiolucency, intact periodontal ligament space. Take these teeth out completely and take a radiograph to show that you did. This is showing you on the right here, we do not have a diagnostic radiograph. Why? Remember I said 3 millimeters around the apex, that periapical region. Why does that matter? Look over here. Oh my goodness, we have the biggest periapical lucency. So super important. We would have totally missed that if we didn't have a diagnostic radiograph. I know these radiographs can be hard to get sometimes. So just making sure that we are getting all of that region around the tip of the root of the tooth. So I put this in here because this is the mandible of a dog. This is our first premolar tooth. And this right here would be one of the only times that I would ever consider monitoring a root, okay? And that comes with a whole lot of ifs. That would also be if I have committed owners that are going to come back for follow-up. If I have absolutely no reaction anywhere around this root, if I have bone that has filled in around that, if the root that is there is smooth, if the patient is going to be a good candidate for additional anesthetic events. So there's a whole lot of ifs, guys. We don't just have rules on when we can leave these roots behind. There's a bunch of things on what it depends on, but we also have to be realistic about this. We can't take out every root that's ever left behind, but we need to make sure we take out every root that has any evidence of disease. So here, this would have been a first premolar tooth on the bottom in the dog. And what do we see here? This is a dentigerous cyst. So what happens is that the teeth, as they're erupting, they have this little layer that's over the top of the crown. And once it goes above the gum line, this cool little embryologic structure goes away. Well, what happens when it does not go above the gum line? Then instead, that fills and fills and fills and becomes a cyst. Dentigerous cysts are not cancerous. However, they are very aggressive oftentimes. So they destroy bone, they destroy teeth. You can see the bone and the teeth in this region that are destroyed. So just making sure that that is why we are counting teeth, right? We want to make sure that we don't end up with cysts. And they don't only happen with first mandibular premolar teeth in dogs. Cysts can happen with unerupted teeth. Dentigerous cysts have to have unerupted teeth. There are also other kinds of cysts that can happen in the mouth. Cat, mandible, wow. So we might look at this and we might say, that probably looks like cancer. Well, not necessarily. Actually, there was a study that came out to show that about half the time that we see something like this, it's cancer, and about half the time it's osteomyelitis. So when this cat came to me, it looked like this. A very well-intentioned veterinarian decided that they didn't need to do a flap. Maybe they were taught they didn't need to do a flap. I don't know, but they did need to do a flap. They did need to get in there and do something about it because it's not appropriate to not close these, right? So this was a significant case of osteomyelitis. When you see those mandibular swellings, those rostromandibular swellings in your cats, it does not automatically mean that it's something really, really bad. This is tooth resorption in a cat. We have type 2 here, where we have narrowing or disappearance of that periodontal ligament space in at least some capacity. We have type 1. So we are going to treat those teeth differently, making sure that we're identifying that, right? This is a cat. This is the mandible. This is the right side. This is going to be some more retained tooth roots. They're jagged. They need to go. They have problems, so get them out of there. This is my very own dog, the very last radiograph that I took of him. So this is, we are missing this mid-root section of this tooth. This is tooth resorption in dogs, guys. It's not fun. It's hard to know what to do with it. You know, when you have good owners who are committed, they're going to come back for follow-up. We're going to be able to monitor these teeth. I monitored this tooth, right? I chose to monitor this tooth. I didn't have cone beam CT at the time. I chose to monitor this tooth, and to my knowledge, that was an okay decision. It was not at or above the gum line. What do we see here? Well, this is a dog. This is going to be the upper jaw or maxilla. This is going to be the right side, and this is going to be a whole lot of bone loss. So we want to make sure that we're making decisions based on the amount of bone loss that we have, remembering that we are measuring that bone loss on the root of the tooth. This is going to be a cat. We might say, oh gosh, I can start to see something going on here. Yeah, absolutely something going on here. And guess what? That tooth has been dead for a long time. And I mean a long time right here, right? So part of the reason I put this in here is because a lot of people say things to me like, well, there's not enough tissue to work with in the mouth of a cat. I can't make flaps. I can't close them. I can guarantee you that there are ways to close them and there are ways to work with that tissue. As you can see on the right there, you can see I removed all of that was going on in the left. So it's just a matter of learning how to handle those tissues. And when we meet again in March, we're going to cover some of those things when we cover some tips and tricks for extractions. So that would be a good time to come back and learn some of that. But a couple of tricks and tips for taking radiographs while we're here. One thing that I want to mention is that the apex of the maxillary canine tooth, mandibular as well, but the apex of these canine teeth in dogs actually is in line with our mesial root of our second premolar tooth. So why does that matter? That matters because if you are struggling to get that apex in your images, maybe you're not back far enough. So put your plate, put your sensor in the mouth far enough back that you are in line with that second premolar tooth. That mesial root is going to mark where your apex is. You can usually feel it when you feel it in the mouth, but you want to make sure that you are far enough back. All the time we see people that are struggling to get this image, and it's a super important one to be able to get. But one of the things that's really going to help you is making sure that you know the anatomy of these teeth. Another image that a lot of people struggle to get, and so I put this on here for you to show you, is that all the way in the far, far back of the mouth, we have these mandibular molar teeth, right? In dogs, we have 3 of them. And so we have this really big one, and then behind it, we have 2 more. These little guys right back here. And in order to get them, this direction is how a lot of people like to try to shove their plate in, further and further and further and further and further back. Well, if all you do is push the plate in further and further back, you're not going to get your image. However, if you take that plate and you push this corner down with your finger like this right here, then when you try to view those teeth, they're actually going to show up. So you can take that image like this. And on here, you can see if you're coming from the front of your patient or towards the nose here, if you're coming from this angle and you're trying to get those teeth on that rad and you're still struggling, try switching to this. Try coming from behind just a little bit, and that's going to allow you to cast the shadow from the teeth in the far, far back just a little bit more onto your plate there. This is going to be one tip that I have for you when it comes to cheek teeth and the maxilla of cats. You're going to need to come further off to the side than what you probably think. And when I say further off to the side, I mean off of the muzzle and down kind of near closer to towards the mandible is what I mean. So instead of being up here, you're going to be over here. And so that would be one tip that I have for you when it comes to taking radiographs for maxillary cheek teeth in cats. So what do we see here? Oops, I just gave it away. When we look at this, I got this image sent to me once upon a time by a good friend of mine. And she said, what do I do with this? And I said, send me a picture of the mouth. And the mouth looked like this. And you can see this chunk of calculus here. And the reason that I put this in here is because when it comes to dental radiographs, it's really, really easy to get really caught up in overinterpreting them. And we want to be super careful and super cautious that we always take a step back and we identify what's going with our patients' mouths too. When we send out a dental radiograph for interpretation and we don't include clinical images, it's impossible to know exactly what's going on with our patients and the whole story and the whole picture for those recommendations. So just keep in mind that there's more to your patient than just what you're seeing on the radiograph. Maybe take a step back and evaluate the bigger picture too. Don't get too caught up in over interpreting things. Identify the stuff that's going to be easy to identify and then make your decisions from there. You're going to get more familiar with it the more you take full mouth rads. The more normal you see, the easier it's going to be to identify abnormal. So I want to say thank you to everybody again for attending this lecture. Absolutely give yourself a pat on the back. We definitely appreciate you showing up tonight. And then I have on here my email address. If you are not already following us on social media, we do post some fun cases from time to time. And then coming out in the next month or so, I will have an online dental education platform where we're going to actually be able to teach a little bit more of all of this stuff in a little bit more detail too. So thank you so much.
Thank you, Dr. Burning. You were a beast to get through all of those slides in that amount of time. That was so much great information. Thank you so much for the wonderful presentation. We're going to open it up for questions now, and we've been getting a flood of just fantastic questions in the Q&A box throughout the presentation. So we have lots of good stuff to talk about still. But remember that the 50-minute mark has passed. So if you would like to get your CE certificate, you can click on that yellow icon in the bottom of your screen. We are going to get to as many questions as we can, but we are definitely not going to get to all of them. But the IM3 team has very generously offered to take the list of questions and get some answers from Dr. Burning for you. So if we don't get to your question, don't worry, they will actually take a look at them and Dr. Burning will figure out how to best answer them. As I mentioned at the beginning, IM3 is offering 10% off of any imaging needs for the next week for our attendees of this live presentation. So you can just email David Liston, the National Sales Manager for IM3, at dleisten@im3.com, or im3usa.com, excuse me. That's dleisten@im3usa.com. And now we'll jump into some questions. Okay, so we have a lot of questions about telling right from left on radiographs. So I want to start with that because we had a bunch of people ask about that.
Sure, so I will go back to this. So this would be as if your patient is looking at you. So if you had a dog in front of you, let's see if I can draw a dog with my mouse. Probably not very easily at all. Here's its nose, here's its eyes, here's its ears. Okay, great. Here's your dog. It's looking at you. This is the right side of your dog's mouth. This is the left side of your dog's mouth, right? So when you have radiographs that are like this, it would be as though you lifted the lip and you saw this canine tooth right here. And then the same thing on this side, you would see this canine tooth over here, or this canine tooth, you know, it's all the same. But that tooth is going to look just like if you lifted the lip of that patient, what you're going to see with that patient looking at you. So hopefully that is helpful for those of you who are asking the question.
Thank you. Mm-hmm. We also have a few people who have asked why it's so important to take out unerupted teeth. And I'm going to go ahead and expand that to say, you know, what about retained roots that don't seem to be causing any problem, but you notice them, they're there? Sure.
So when the unerupted teeth, so let's say that you have an 11-year-old patient and you found an unerupted 305 and there is absolutely no evidence of a widening at the crown of that tooth, and these are people who are going to come back to you for monitoring, you're probably going to be fine to monitor that, okay? But if you are in that mouth early and you find that you have an unerupted tooth, it is very possible that that is going to turn into a dentigerous cyst. In the worst situations, dentigerous cysts become very large and can result in mandibulectomies. So I also had one case that bilateral dentigerous cysts went through a morphing phase and actually became squamous cell carcinoma. So it is definitely worth, if you're in the mouth early and you are identifying something early or you see a widening around it, getting those teeth out if you are identifying that in a much older patient and there is absolutely no evidence of widening of that region, you're probably going to be more okay. With retained tooth roots, for instance, cats, I would get them out of there. It is super, super rare that a cat is going to have complete healing around a retained tooth root. I can just tell you how many of them I see. I see them at least once a day in practice, retained tooth roots in cats that are causing problems. They cause problems. They just do. It's just the reality. Get them out. Do not leave them. In dogs, occasionally, if you see absolutely no evidence of gingival inflammation, you see total healing all the way around it, you have owners that are going to come back for monitoring. You know, this is one of those things where there's always the argument of, well, in people, they leave these roots. I get it, guys, but guess what? People can talk. Your patients cannot talk. They cannot talk. They cannot tell you when they are in pain. And if there is one thing that we need to be doing, it is being the voice for our patients. When they might be suffering silently, we have no idea or way to know that, other than knowing that while we can sometimes leave tooth roots in people without them causing pain, sometimes we can't, and they cause a lot of pain. So I'm not willing to take that guess.
Thank you for that answer. And I just want to say that dentigerous cyst is like my favorite vet med term. It sounds like somebody just made it up. It's so good. We have a few questions about positioning for radiographs. So we had a couple of people ask if you do your dental rads in lateral or in dorsal accumbency or ventral.
Yeah, so that's a good question. So we do ours in lateral at my practice, but I have been teaching dental radiograph positioning for many, many, many years now, and I can teach it in any position because the reality is, as long as you understand the anatomy of the teeth and the angles behind what you're doing. And I don't mean by looking at 35 degrees and all of that. I don't do them that way. I understand the anatomy of the tooth. I understand where I need to come from in order to get that tooth to show up on my image and make adjustments accordingly. So the most important thing we do when we take dental radiographs is we look at an image and we say, what do I need to change? Do I need to change the angle of my generator, or do I need to move the position of my sensor? And you don't want to do both. You do one or the other, and then you take another image. You wait until it comes up before you judge it. And then it comes up, and then you decide what you need to do next. Did you get what you wanted in the film that time, or do you need to make another adjustment? But you can take them. There are plenty of people who swear that their way is the only way. I'm not one of those people. I need people to do what works best for them in practice. And so if you want to take all of your radiographs in sternal, or if you want to take them all flipped on their back, however you want to do it is fine. However, the biggest thing that I run into is when technicians learn to only take radiographs when their patients are in sternal, but the doctors only know how to take teeth out with the patients in lateral, and you want to know whether or not you have all of the tooth out, you have to flip your patient again in order for your team to know how to take a radiograph to see if you have a retained tooth root. And if you do, then you have to flip them back to lateral, and then you keep working, and then you want to know again if you got it all, and then you flip them back to sternal. And as you can see, that is going to lead to, let's just not take the rad, I'm sure it's out. Wrong. Wrong, wrong, wrong. That's the part that's wrong, right? The part where we want to cut corners, that's the part where I'm going to say it's wrong. So we don't want to cut corners. Find what works for you in practice. If the only way your team knows how to take rads is not the position that you know how to extract teeth, maybe we try to find a different way for you to figure out how your team can take rads so that it's practical peri-operatively too.
Thank you. We're at the top of the hour now, so I know we've been here for an hour, and you're a trooper for hanging in there and continuing to answer questions, and maybe we'll do one more question
Sure.
so that everybody can get on with their day. But like I said, we have tons of questions still coming in, and we will forward them on to the IM3 team who can get answers for everyone because there's definitely no way we're going to be able to get to all of them. So there are lots of questions about extractions in the Q&A, and these are really good questions. As a primary care vet, I love these questions. And so this is a really good reminder to come to your next lecture in March, which I'll mention the date here in just a second. But I'm going to actually leave those right now because you are going to be doing a whole presentation on extractions coming up in March. So the one question that I see a lot of people asking which is always a tricky one, is about monitoring tooth resorption. So in a cat or a dog, if you see a little bit of resorption, how do you know when you have to take the tooth out and when it's okay to monitor?
Sure. So when we see tooth resorption at or above the gum line, we know that it's painful. We extrapolate that from human dentistry. So tooth resorption also happens in people. I spend a lot of my time talking to human dentists. So my dad's a dentist, my brother's a dentist. I spend a lot of time on the human dental side. So we know from people that tooth resorption at or above the gum line is painful. So we definitely want to treat it in those situations. Anytime that that's the case, we want to make sure we treat it. What if it's really, really close? Well, unless your patient's going to come back in like 3 months, you probably also need to treat it. Let's say that you have never seen this patient, or maybe they were supposed to come in for when you recommended a procedure every 6 months or every 9 months or every 12 months, and now it's been 3 years. So a lot of it depends on owner compliance, because if you don't have compliant owners, monitoring is not the option. If you're not going to be able to monitor, monitoring is not the option. So there are a whole lot of factors to consider. There's not, other than if it is at or above the gum line, we have to take it out. There's not one rule to follow. It really depends on the situation. It depends on underlying conditions in your patients. It depends on if you have radiographs from 6 months ago and now you've taken them again and there's been no progress. Well, now we might be able to go 9 or 12 months. Now there's been no progress. Well, now we might be able to go 12 or 16 months. And then we start to see, we certainly see animals that have tooth resorption, and then we get back in there in 6 months and it's really progressed. And that's the thing with it, is that you have to have somebody who's going to come back if monitoring is your choice. So you can't just say you're going to monitor, but not actually monitor. So making sure that the owner is on board with that plan before you make that plan is a really important thing.
All right, thank you so much, Dr. Burning. This was fantastic. A really comprehensive presentation, and yet we still have so many good questions. So I love how engaged everybody's been in this webinar. And a huge thanks to IM3 as well. Remember that IM3 is offering 10% off of imaging needs for the next week for attendees of this webinar live. You can email David Liston, that's spelled Leisten, the National Sales Manager for IM3, and his email address is dleisten@im3usa.com to redeem that 10% discount. For those of you who joined us live today, don't forget that you can download your CE certificate from the yellow icon in the toolbar or from the box at the bottom right corner of your console before we close out. If you're not able to download your certificate now, you can come back to this event console anytime to do so. So if you miss it tonight, it's not gone forever. For those who are watching on demand, please reference the box in the bottom right corner for information on how you can get your CE credit for today's presentation. And if you enjoyed Dr. Burning's talk today, don't miss that next webinar with IM3 on March 25th, 2024, when she'll be covering some top tips to make extractions easier, which, judging from the questions, I think that one will be very well attended as well. I know I'm going to be there. And if you missed it, you can catch the first webinar that Dr. Burning did with IM3, where she answers all the questions about dentistry that you might feel like you should know by now, but you don't really want to ask. That's on demand right now at cliniciansbrief.com. Thank you again, Dr. Burning. Thanks to IM3, and thanks to all of you for joining us, being such an engaged audience, and have a wonderful rest of your evening.
Bye, everybody. Take care.